Welcome to This Explainer. Today, we're going to build a super practical playbook for managing osteoporosis, one you can use every single day, right from the pharmacy counter. So let's just start with the sheer scale of this problem. In Canada alone, we're talking about 2.2 million people over 40 who've been diagnosed with osteoporosis. It's a huge public health issue. And you know what? We're right there on the front lines. So here's how we're going to break it all down. First, we'll get into what this silent disease is all about. Then we'll talk about spotting at-risk patients, cover the go-to medications, dive deep into the most important counseling points, and finally, tackle some advanced management scenarios. Okay, let's dive right in. First things first, we need to have a really solid foundation of what osteoporosis actually is and what's happening on a physiological level. At its absolute core, osteoporosis is just a loss of bone strength. Simple as that. And it's this weakened, compromised structure that makes fractures from even minor bumps or simple movements so much more likely. So what's really going on under the hood? Well, it's all about a remodeling imbalance. See, our bones are in this constant state of repair. Old bone gets cleared out and new bone gets built. But with osteoporosis, that system gets out of whack. The demolition crew starts working way faster than the construction crew. Okay, with that foundation in place, let's talk about where you come in. This is about your proactive role at the counter, spotting those at-risk patients, sometimes before they even have a clue. When you're looking at a patient's profile, these are the big red flags. A previous fragility fracture, that's a huge one. But you also want to keep an eye out for things like rheumatoid arthritis, or if they mention a parent had a hip fracture. These are all major predictors. And this is our sweet spot, isn't it? The medication review. Long-term steroid use is the classic culprit, but you gotta watch for others too, like aromatase inhibitors. And hey, even super common meds like PPIs and SSRIs have been linked to a higher risk. So all these different risk factors get plugged into these really clever tools like FRAX. It crunches the numbers and spits out a 10-year probability of a major fracture. And that's what really helps guide the decision to start therapy, especially when someone lands in that high-risk zone, over 20%. All right, now for our toolkit. When it's time to treat, the medications pretty much fall into two camps. I like to think of them as the brakes and the builders. So you've got the brakes. These are your anti-resorptives. Their whole job is to slow down that demolition crew, the osteoclasts, to stop more bone from being lost. Then you have the builders, the anabolic agents. They actually kickstart the osteoblasts to build brand new bone. Most of our first-line drugs are going to be brakes. And here are the star players you'll see every day. The bisphosphonates and denosumab are your workhorse anti-resorptives, or brakes. The builders, like teriparatide, well, those are usually kept for more severe cases, like when a patient has already had a fracture or their bone density is just really, really low. Okay, this next section is, in my opinion, the most important part of our day-to-day job. These are powerful drugs, but they only work and are only safe if patients use them the right way. This is where we make a massive difference. For oral bisphosphonates, these 4 steps are absolutely 100% non-negotiable. And we have to make sure our patients get why. The bioavailability is already terrible, less than 1%, so any food or drink messes it up. And staying upright with plain water, that's all about preventing some really nasty esophageal irritation. Think of this as your quick reference cheat sheet. For bisphosphonates, the big things are GI upset and hammering home those strict rules. For denosumab, the number one can't-miss point is the rebound fracture risk if they just stop taking it. And with teriparatide, you've got to warn them about potential dizziness with the first doses, and of course, to keep that pen in the fridge. Okay, last but not least, let's get into some of the more complex stuff. The questions that come up after a patient has been on therapy for years. We're talking drug holidays and those rare but serious side effects. This is a big one, right? The drug holiday? We get this question all the time from both patients and doctors. Is it safe to take a break from the bisphosphonate after a few years? Well, the answer really depends. It comes down to the patient's risk level and which drug they're on. For someone at moderate risk who's on a long-acting drug like alendronate, yeah, a break might be okay. But for a high-risk patient or someone on risedronate, continuous therapy is almost always the way to go. And this chart just puts everything into perspective. People worry about atypical femur fractures, and yes, they're a real risk, but look at the numbers. They're incredibly rare.
like 11 cases per 100,000. Now, compare that to the number of devastating hip fractures these drugs prevent. It's not even close. The benefit is just overwhelming.
So the key here is to empower our patients. We need to tell them exactly what to watch out for. Any new nagging pain in their thigh or groin, they need to call their doctor right away. That one piece of advice can help catch a problem early before it becomes a full-blown fracture. Now, this is so important to remember. Denosumab is a completely different animal from bisphosphonates. When you stop it, it doesn't hang around in the skeleton. Instead, you get this massive rebound effect where bone loss goes into overdrive, creating a huge risk for new spine fractures. And that's exactly why a drug holiday is never, ever an option for denosumab. If it has to be stopped, you absolutely must bridge them to something else. The standard of care is to follow that last dose with a 1 to 2 year course of a bisphosphonate to lock in those gains and slam the brakes on that rebound. So we've built the playbook, from spotting that at-risk patient to counseling on the really complex stuff. The only question left is, which patient are you going to use this knowledge to protect today?